Welcome to today's pharmacology session. In this video, we'll review a comprehensive list of critical emergency and ICU medications, covering their mechanisms of action, dosing, acute clinical indications, and key precautions. From antidotes and antiarrhythmics to sedatives, analgesics, and neuromuscular blockers, this lecture is designed to provide high-yield, expert-level insights for pharmacists, clinicians, and healthcare professionals managing acute and life-threatening conditions. By the end of this video, you'll have a solid understanding of how to safely and effectively use these drugs in critical care scenarios. Acetylcysteine, commonly known by the brand name Mucomyst, which is the antidote of choice for acetaminophen overdose. Acetylcysteine works through several important mechanisms. First, it replenishes hepatic glutathione stores. During an acetaminophen overdose, toxic metabolites, particularly NAPQI, rapidly deplete glutathione in the liver. When glutathione levels fall, these toxic metabolites begin to damage liver cells, leading to hepatic injury. Acetylcysteine helps prevent this damage by restoring glutathione levels, allowing the toxic metabolite to be detoxified safely. In addition, acetylcysteine can also serve directly as a glutathione substitute, meaning it can bind to and neutralize toxic intermediates when natural glutathione levels are insufficient. Another important mechanism is that acetylcysteine enhances sulfate conjugation of acetaminophen, which promotes safer metabolic pathways and further reduces the formation of toxic metabolites. Now let's review the dosing regimens. For oral administration, the standard regimen begins with a loading dose of 140 mg per kilogram, followed by 70 mg per kilogram every 4 hours for 17 additional doses. This oral treatment course lasts a total of 72 hours. For intravenous administration, acetylcysteine is typically given using a 3-infusion protocol over 21 hours. First, a loading dose of 150 mg per kilogram is administered in 200 ml of D5W over 1 hour. Next, 50 mg per kilogram is infused in 500 ml of D5W over 4 hours. Finally, 100 mg per kilogram is administered in 1 liter of D5W over 16 hours. It is important to note that therapy may need to be extended beyond the standard 21-hour IV protocol if laboratory parameters such as liver function tests and acetaminophen levels have not yet normalized. The primary acute clinical indication for acetylcysteine is acetaminophen toxicity or overdose, where early administration significantly reduces the risk of acute liver failure. Now let's review contraindications and precautions. One potential adverse effect is a hypersensitivity reaction, particularly with the intravenous formulation. If this occurs, the infusion should be stopped temporarily, and management may include slowing the infusion rate or switching to the oral formulation. Although uncommon, hypersensitivity reactions can also occur with oral acetylcysteine. Finally, acetylcysteine is classified as pregnancy category B, meaning that available data suggests no evidence of risk in humans, and it may be used during pregnancy when clinically indicated. Overall, acetylcysteine remains a critical and life-saving antidote in the management of acetaminophen toxicity, especially when administered early after overdose. Adenosine, which is marketed under the brand names Adenocard and Adenoscan. Adenosine is a short-acting antiarrhythmic medication that is primarily used in the acute management of supraventricular tachycardias. Let's begin with its mechanism of action. Adenosine works by activating A1 receptors located in the atrioventricular, or AV, node. Stimulation of these receptors causes transient slowing of AV nodal conduction. This results in a temporary AV nodal block, which briefly interrupts the abnormal electrical circuit responsible for certain tachyarrhythmias. Because of this effect, adenosine is particularly effective in terminating re-entrant tachycardias that involve the AV node. One important pharmacokinetic feature of adenosine is its extremely short half-life, typically less than 10 seconds, which is why the drug must be administered very rapidly by intravenous push. Now let's review the dosing protocol. The initial recommended dose is 6 mg given as a rapid IV push. Because of its rapid metabolism, the medication must be followed immediately by a rapid saline flush to ensure it reaches the heart quickly. If the arrhythmia does not convert after the initial dose, a 12 mg IV rapid push may be administered after 2 minutes. If necessary, a second 12 mg dose may be given again after another 2 minutes, for a maximum of 2 repeat doses. Now moving to the acute clinical indications. Adenosine is primarily used for the acute treatment of stable supraventricular tachycardia, commonly referred to as SVT. It is also effective in stable narrow complex tachycardias, particularly when the rhythm involves the AV node in the reentry pathway. Because adenosine temporarily blocks AV nodal conduction, it can both terminate certain tachyarrhythmias and assist in the diagnostic evaluation of unclear supraventricular rhythms. Next, let's discuss contraindications and precautions. Adenosine has pro-dysrhythmic potential, meaning it can occasionally trigger other abnormal heart rhythms. For this reason, it should be administered under continuous cardiac monitoring. It is contraindicated in patients with pre-existing second-degree or third-degree AV block, unless the patient has a functioning pacemaker. Since the drug further suppresses AV nodal conduction, administering it in these patients could lead to severe bradycardia or complete heart block. Finally, regarding pregnancy safety, adenosine is classified as pregnancy category C, which means that risk cannot be ruled out, and the drug should be used only when the potential benefit justifies the potential risk to the fetus. Overall, due to its rapid onset and extremely short duration of action, adenosine is considered a first-line pharmacologic therapy for the acute termination of stable supraventricular tachycardia. Albuterol, which is commonly marketed under the brand names Proventil, ProAir, and Ventolin. Albuterol is a short-acting beta-2 adrenergic agonist, often referred to as a SABA, and it is widely used in the management of acute bronchospasm. Let's begin with the mechanism of action. Albuterol works by selectively stimulating beta-2 adrenergic receptors located in the smooth muscle of the bronchial airways. Activation of these receptors leads to relaxation of bronchial smooth muscle, resulting in rapid bronchodilation. This helps to relieve airway obstruction and improve airflow in patients experiencing bronchospasm. In addition to its bronchodilatory effects, stimulation of beta-2 receptors also promotes intracellular shifting of potassium, which explains why albuterol can be used as an adjunct treatment for hyperkalemia. Now let's review the dosing in acute settings. For nebulized therapy in acute bronchospasm, the typical dose is 2.5 to 5 mg administered every 20 minutes during the first hour of treatment. After the initial hour, dosing may be adjusted to 2.5 to 10 mg every 1 to 4 hours as needed, depending on the patient's response and severity of symptoms. An alternative approach in severe cases is continuous nebulization, where 10 to 15 mg may be administered over a 1-hour period. Now moving to the acute clinical indications. Albuterol is primarily used for the treatment of acute bronchospasm, such as in asthma exacerbations or other obstructive airway conditions where rapid bronchodilation is required. It is also used as an adjunctive therapy in hyperkalemia, where its beta-2-mediated effect helps shift potassium from the extracellular space into the cells, temporarily lowering serum potassium levels. Now let's discuss the contraindications and precautions. Because albuterol stimulates adrenergic receptors, one of the most common adverse effects is tachycardia, which occurs due to some degree of beta-1 receptor stimulation or reflex cardiac stimulation. Patients may also experience hyperglycemia, as beta-2 receptor activation can increase glycogenolysis and gluconeogenesis. Another important metabolic effect is hypokalemia, which occurs because potassium shifts from the bloodstream into the cells. Therefore, clinicians should use caution when administering albuterol to patients who are already at risk for electrolyte imbalances or cardiovascular complications. Finally, regarding pregnancy safety, albuterol is classified as pregnancy category C, meaning that it should be used only when the potential benefits outweigh the potential risks to the fetus. In summary, albuterol remains a first-line, rapid-acting bronchodilator that plays a critical role in the emergency management of acute bronchospasm, while also serving as an important adjunct therapy in the treatment of hyperkalemia. Amiodarone, which is commonly marketed under the brand name Pacerone. Amiodarone is a widely used antiarrhythmic medication and is classified primarily as a Class III antidysrhythmic agent. Let's begin with the mechanism of action. The primary action of amiodarone is blocking potassium efflux from cardiac cells, which prolongs phase 3 repolarization of the cardiac action potential. By delaying repolarization, amiodarone prolongs the refractory period of cardiac tissue, helping to stabilize abnormal cardiac rhythms. Although it is classified as a Class III antiarrhythmic, amiodarone is unique because it also exhibits properties of several other antiarrhythmic classes. It has Class I activity, meaning it can block sodium channels, which slows conduction through cardiac tissue. It also has Class II effects, producing beta-adrenergic blocking activity, which helps reduce sympathetic stimulation of the heart. In addition, amiodarone has Class IV activity, meaning it can block calcium channels, contributing to further suppression of abnormal electrical conduction. Because of this multi-class activity, amiodarone is considered a broad-spectrum antiarrhythmic agent. Now let's review the dosing in acute cardiac emergencies. In cases of pulseless ventricular fibrillation or pulseless ventricular tachycardia, the recommended dose is 300 mg administered as a rapid intravenous push. If the arrhythmia persists, an additional 150 mg IV rapid push may be administered at the next pulse check. For stable wide complex tachycardias, the dosing strategy is slightly different. In this situation, 150 mg is administered intravenously over 10 minutes. This is then followed by a continuous infusion of 1 mg per minute for 6 hours, and afterward the infusion rate is reduced to 0.5 mg per minute for maintenance therapy. Now let's review the acute clinical indications. Amiodarone is commonly used in the management of pulseless ventricular fibrillation and pulseless ventricular tachycardia, particularly when these rhythms are refractory to defibrillation. It is also used for wide complex tachydysrhythmias, where stabilization of abnormal ventricular rhythms is necessary. Finally, let's discuss contraindications and precautions. One important adverse effect associated with intravenous amiodarone is hypotension, which may occur due to vasodilation and myocardial depression. Amiodarone also has pro-dysrhythmic potential, meaning that in some cases it may actually induce or worsen arrhythmias, particularly in patients with underlying cardiac conduction abnormalities. For this reason, it should always be administered under close cardiac monitoring. Regarding pregnancy safety, amiodarone is classified as pregnancy category D, indicating positive evidence of fetal risk, and therefore it should only be used when the potential benefits outweigh the risks in life-threatening situations. In summary, amiodarone is a powerful broad-spectrum antiarrhythmic medication that plays a critical role in the emergency management of life-threatening ventricular arrhythmias, particularly pulseless ventricular fibrillation and ventricular tachycardia. Atropine, which is commonly available under the brand name Atropine. Atropine is an important medication used in toxicology and emergency cardiac care, particularly in the management of organophosphate poisoning and symptomatic bradycardia. Let's begin with the mechanism of action. Atropine acts as a direct anticholinergic agent, meaning it blocks the action of acetylcholine at muscarinic receptors in the parasympathetic nervous system. By inhibiting these muscarinic receptors, atropine reduces parasympathetic activity, which leads to effects such as increased heart rate, decreased secretions, and relaxation of smooth muscle in certain organs. This mechanism is particularly important in organophosphate and carbamate toxicity, where excessive acetylcholine accumulation leads to severe cholinergic symptoms, including excessive salivation, bronchial secretions, bronchospasm, and bradycardia. Now let's review the dosing protocols for different clinical scenarios. In cases of organophosphate or carbamate toxicity, atropine is administered intravenously at 1 to 6 mg every 3 to 5 minutes as needed. Treatment is continued until bronchial secretions become adequately controlled and the patient's airway is clear. In severe poisoning, the dose can be doubled with each administration until an adequate clinical response is achieved, as very large doses may be required to counteract the overwhelming cholinergic effects. For pediatric bradycardia, atropine is dosed at 0.02 mg per kilogram given intravenously as a single dose. The maximum single dose is 0.5 mg, with a maximum cumulative dose of 1 mg. For adult bradycardia, the recommended dose is 0.5 mg administered intravenously, and doses may be repeated as needed up to a maximum cumulative dose of 3 mg. Now let's review the acute clinical indications. Atropine is commonly used in the treatment of organophosphate and carbamate poisoning, where it helps reverse life-threatening cholinergic toxicity by reducing excessive secretions and improving heart rate. It is also used in the treatment of symptomatic bradycardia, particularly when low heart rate is causing hemodynamic instability. Now let's discuss the contraindications and precautions. Atropine should be used cautiously in hyperthermic patients, as anticholinergic medications can reduce sweating and potentially worsen heat retention. It should also be used carefully in patients with tachydysrhythmias, since atropine increases heart rate and may further aggravate existing abnormal cardiac rhythms. Finally, regarding pregnancy safety, atropine is classified as pregnancy category C, meaning that it should be used only when the potential benefits justify the potential risks to the fetus. In summary, atropine is a key anticholinergic medication in emergency medicine, playing a critical role in reversing cholinergic toxicity from organophosphate poisoning and treating symptomatic bradycardia. Calcium gluconate and calcium chloride, which are intravenous calcium salts commonly used in emergency and critical care settings to stabilize cardiac function and correct severe electrolyte disturbances. Let's begin with the mechanism of action. Both calcium gluconate and calcium chloride work by increasing serum calcium levels. More importantly, in emergency medicine, they help stabilize cardiac myocytes, particularly the cardiac cell membrane. In conditions such as severe hyperkalemia, elevated potassium levels can destabilize the cardiac membrane and lead to dangerous cardiac dysrhythmias. Administration of intravenous calcium helps restore the electrical stability of the cardiac membrane, thereby reducing the risk of life-threatening arrhythmias. Now let's review the dosing information. Both calcium gluconate and calcium chloride are commonly available as 10% intravenous solutions. A 10% solution contains 1 gram of the calcium salt in 10 milliliters of solution. These medications are typically administered intravenously in emergency situations where rapid cardiac membrane stabilization is required. Now moving on to the acute clinical indications. Intravenous calcium is frequently used in the management of hyperkalemia, where it helps stabilize the myocardium and reduce the risk of cardiac arrhythmias, while other treatments are used to lower potassium levels. It is also used in cases of severe hypocalcemia associated with cardiac dysrhythmias, where immediate correction of calcium levels is necessary to restore normal cardiac function. Now let's discuss the important precautions and differences between the two formulations. Calcium chloride is approximately 3 times more potent than calcium gluconate because it contains a higher amount of elemental calcium. However, calcium chloride is significantly more irritating to veins and carries a higher risk of severe phlebitis and tissue injury if extravasation occurs, especially when administered through a peripheral IV line. For this reason, calcium gluconate is generally preferred for peripheral administration, while calcium chloride is more commonly used through central venous access in critical care settings. Calcium administration should also be used cautiously in patients with pre-existing dysrhythmias or tetany, as rapid changes in calcium levels can affect neuromuscular and cardiac activity. Finally, regarding pregnancy safety, both calcium gluconate and calcium chloride are classified as pregnancy category C, meaning they should be used when the potential clinical benefit outweighs potential fetal risk. In summary, intravenous calcium, either as calcium gluconate or calcium chloride, is an essential emergency medication used to stabilize the myocardium in hyperkalemia and to treat severe hypocalcemia associated with cardiac dysrhythmias. Diazepam, which is commonly known by the brand name Valium. Diazepam is a medication that belongs to the benzodiazepine class, and it is widely used for its sedative, anxiolytic, anticonvulsant, and muscle relaxant properties. Let's begin with the mechanism of action. Diazepam works by enhancing the inhibitory effects of gamma-aminobutyric acid, or GABA, which is the primary inhibitory neurotransmitter in the central nervous system. Specifically, diazepam binds to benzodiazepine receptor sites on the GABA receptor complex, increasing the frequency of chloride channel opening. This results in greater neuronal inhibition, producing effects such as sedation, muscle relaxation, anticonvulsant activity, and reduction of anxiety. Now let's review the dosing information. Diazepam can be administered through multiple routes, including oral, intravenous, and intramuscular administration. The typical dosing range is 2 to 10 milligrams given every 6 hours as needed, depending on the clinical indication, patient condition, and response to therapy. Now moving to the acute clinical indications. Diazepam is commonly used for seizure abortion, where its rapid action helps terminate active seizure activity. It is also frequently used in the management of alcohol withdrawal, where benzodiazepines help control symptoms such as agitation, tremors, and risk of withdrawal seizures. In addition, diazepam may be used to treat acute agitation, as well as muscle spasms, due to its central muscle relaxant effects. Now let's discuss the contraindications and precautions. One of the most important risks associated with diazepam is respiratory depression, particularly when administered intravenously or when combined with other central nervous system depressants, such as opioids or alcohol. Diazepam can also cause hypotension, especially in higher doses or in patients who are already hemodynamically unstable. Because of these risks, patients receiving diazepam, especially in acute settings, should be closely monitored for respiratory and cardiovascular function. Finally, regarding pregnancy safety, diazepam is classified as pregnancy category D, which indicates positive evidence of fetal risk. Therefore, it should be used during pregnancy only when the potential benefits outweigh the potential risks. In summary, diazepam is a rapid-acting benzodiazepine that enhances GABA-mediated neuronal inhibition, making it an important medication for seizure management, alcohol withdrawal treatment, agitation control, and muscle spasm relief. Diltiazem, which is commonly marketed under the brand name Cardizem. Diltiazem is classified as a non-dihydropyridine calcium channel blocker, and it is frequently used in the management of certain supraventricular cardiac arrhythmias. Let's begin with the mechanism of action. Diltiazem works by inhibiting calcium influx through L-type calcium channels in cardiac and vascular smooth muscle cells. Its effects are more pronounced in the myocardium compared to vascular smooth muscle. By blocking calcium entry into cardiac cells, diltiazem reduces conduction through the atrioventricular, or AV, node and prolongs AV nodal conduction time. This helps slow the ventricular response in patients with rapid atrial rhythms. In addition, diltiazem produces mild vasodilation, which can contribute to lower blood pressure. Now let's review the dosing in acute care settings. For the treatment of supraventricular tachyarrhythmias, the initial dose is 0.25 mg per kilogram administered intravenously as a single dose. If the desired therapeutic response is not achieved, a second dose of 0.35 mg per kilogram IV may be given after 15 minutes. Once the rhythm or ventricular rate begins to respond, therapy may be continued using a continuous intravenous infusion at a rate of 5 to 15 mg per hour, depending on the patient's response and clinical condition. Now let's review the acute clinical indications. Diltiazem is commonly used in the management of stable atrial fibrillation with rapid ventricular response, often abbreviated as AFib with RVR, where it helps control the ventricular heart rate by slowing AV nodal conduction. It is also used in stable supraventricular tachycardia, or SVT, where suppression of AV nodal conduction can help restore or control normal heart rhythm. Now let's discuss the contraindications and precautions. One important adverse effect associated with intravenous diltiazem is iatrogenic hypotension, which can occur due to its vasodilatory and cardiac depressant effects. Diltiazem may also cause bradycardia, especially in patients who already have underlying conduction abnormalities or are receiving other medications that slow AV nodal conduction, such as beta blockers. For this reason, patients receiving intravenous diltiazem should be closely monitored for blood pressure changes and heart rate abnormalities. Finally, regarding pregnancy safety, diltiazem is classified as pregnancy category C, meaning that it should be used only when the potential clinical benefit outweighs potential risks to the fetus. In summary, diltiazem is a calcium channel blocker that slows AV nodal conduction and reduces ventricular rate, making it an important medication in the acute management of stable atrial fibrillation with rapid ventricular response and stable supraventricular tachycardia. This marks the end of this video. Thank you.